demonstrated in all of the other things that he's been doing, which he's going to tell us about. Martin is a professor at the University of Mannheim, Germany. He's also the director of the Department of Psychosomatics and Psychotherapy at the Central Institute of Mental Health in Mannheim, and he's chair of the Psychosomatics and Psychotherapy group at the University of Heidelberg, and has been doing a lot of really interesting work, which we're delighted to have him tell us about. When I was presenting earlier today, as I mentioned to you, one of the things that we really hope to find better and better ways to do is to achieve some good treatment results on a somewhat shorter time frame with patients with borderline PD. And Martin's been studying a 3-month model of inpatient PD, and he's going to tell us a little bit about that along with some related studies. So let me turn things over to Dr. Focus.
I'm really glad for the invitation. Thank you, dear colleagues. I changed the title of my speak a little bit. This kind of thing you hang around at the airport. You have a lot of time to go over the slides again and again. So I removed the whole thing. I'm talking on effectiveness of this inpatient treatment, but I will show you a little bit step forward data. This means what do we do together with Marsha to lead on and develop stage 2 DBT, and I can show you the first data. So I'm not aware what the speakers before told, but I think there's general agreement that in most of this, on the first glance, real behaviors of the borderline patients have something to do with affective dysregulation. And so you can scope it under this perspective and say most of these improved criteria are either direct consequences of affective dysregulation or dysfunctional coping strategies. And currently we know or familiar with 5 treatments with empirically based data. DBT is currently the most empirically supported treatment. That doesn't mean it's the best, but it's the treatment which has the most data. And what we know is we have now 8 RCTs that found that compared to control conditions, DBT has fewer and less medically severe suicide attempts, excessive interest episodes, lower treatment dropouts, fewer inpatient psychiatric days, improved global and social adjustment, and decreased anger. So this is the data how they are. For those who are not that familiar, DBT is a multi-component treatment. It's primarily focusing on behavior dyscontrol. And there's, as Marshall Linehan has developed strong advice for the psychotherapists to avoid exposure-based procedures for chronic PTSD during stage 1 treatment. And this is more or less the scope where I'm focusing, whether that makes really sense or we can dare to little, let's say, more temperamental treatments. DBT, this is Marsha's view, and I think I really support it. She clearly distinguishes between 3, let's say, here's the 4 levels of disorder, and is designing the treatment according to this level of the disorders. The first level is what she calls severe behavioral dyscontrol. So the first aim in stage 1 is behavioral control, to regain behavioral control. And then level 2 is what she calls quiet desperation. This means patients are still suffering from emotional disturbations, and so the focus, the scope of that treatment is to teach them and for a non-traumatic emotional experience. And then level 3 is problems from living and incompleteness. The data we have, and all the data are published, are only on level 1. I think that's very important. If you try to compare, let's say, Bateman's treatment and Linehan's treatment, you always have to be sure what stages of the disorder we're talking about. And so what I'm going to do, the outline of the presentation, first I want to talk about inpatient DBT, the rationale, why we do it at all, then the data, and then how we further proceed, development of stage 2 treatment, rationale, and the first data. So why do we something crazy like inpatient DBT treatment? So the first thing is we can do it. Insurance company in Germany pay for 3 months inpatient treatment. this is not only Germany, but it's true for France, for Holland, for all the northern countries, for Sweden, Norway. So Europe is still good on Europe. Yeah? Insurance companies pay for that. And when we have the situation is that about 80% of the patients in Germany receive inpatient treatment of borderline patients. And the average inpatient patient stay cost is 66 days per year. So that's a terrific number. This means 50% of our total costs we pay for psychiatric disorders in Germany are for borderline patients. And this is due to this tremendous 66 days a year. The probability for repetitive admission in Germany, if you don't give them specific treatment, is 80%. Show up next year again and again and again. This is something like a turnaround door situation we had in schizophrenic patients 50 or 20 years ago. And what's clear, the reason was there's insufficient outpatient DBT, so we decided to bring the model which has been developed at Cornell. Charlie Swenson had developed the program, I've learned it there, and brought it over to Germany. This is exactly 10 years ago. And so the program is like this. We have a 3-month program. It's a fixed program. Patients wait for it. Yeah? We take them in maybe for at an emergency report something, and then we do our first interviews and try to get them into the program. This means they can come from the emergency ward, but they also can be set on the wait list. We have three steps. The first step is 3 weeks. This means treatment planning, which sounds a lot of time, but we do very, very careful behavioral analysis and program analysis and all that stuff. When patients comes to the team, this was the great idea of Charlie Swenson, to bring the patient with their therapist, the whole team, and they report their program analysis and do their treatment planning. So it's very transparent. Okay. And then we have 7 weeks of treatment. It's individually adapted treatment program. It's different than the outpatient DBT. This means every single patient has his single behavioral analysis, and based on that, his individual skills are taught. And in the step 3, it takes 1 or 2 weeks. We prepare them for going out again. We do something training for staying alone overnight and going back to jobs and being back to practice. So it's a 2 or 3 weeks progress. The treatment models are mixed. We have the education group, individual therapy, 1 hour a week. We have a group skills training, case management, skills utilization group, behavioral analysis group, daily mindfulness. This is important. We really give them daily 20 minutes. Every patient is doing 20 minutes mindfulness there. And we have body therapy. So the data, when we did this controlled study, DBT versus treatment as usual waitlist, 60 females consecutive admitted. Here's the 3 months inpatient treatment. The first post data were 1 month after discharge. I think that's quite important. So you really see what happened to those if they're back in their natural environment. And then they went outside, no further DBT treatment, but treatment as usual. And we had a follow-up data 1 year and 2 years. We included female patients older than 18 years. The DIP-R had to be more than 7, and we diagnosed according to the IPD criteria. No drug or alcohol addiction. Current BME lower than 16 to be excluded in this data. In the treatment, we sent them over to our eating disorder ward. No schizophrenia. I think these are the usual inclusion and exclusion criteria. The participants are, this is just to show you that there's a difference between the DBT and the waitlist. Group mean age is about 30. We have 7.2 or 7.5 at least, and 4 criteria. They have the usual comorbidities, anxieties, or sleep disorders, and so on, no different. And the waitlist was a treating as usual waitlist. This means 15 of the 16 had been in treatment. Most of them in inpatient treatment, average 45 days. A lot of them are afterwards in outpatient treatment, and almost everybody was in medication. The assessment, I think it's fair just to show really everything we assessed, not only the successful data. So we had that was what we usually do in Europe. This means the SM90 was our primary outcome criteria. This is comparable to the Bateman group. Then classic, less classic. We always have self and observer-based system and try to assess the whole cell pathology. What we found in the group over time comparison, after 1 month after discharge, is a significant difference in the SL90, the eye, the Hamilton, the sky, and the gut, and the trend on the NEA. We did not find significant differences in the DES and the STAX. The self-interest behavior also differed significantly. At the end of post-1, they had about 38% who were still cutting. It means a strong criteria. This is cut as non-cutters criteria. And if you look at box plots, this is the SL90. This is pre-treatment. The red one is the way it is. The blue one is the borderline group. And here's the medium. What you see is that we got about 50% of the patients down in the normal functioning level of the SL90 within those 3 months. The effect sizes, weightless versus TBT here. The graph is quite high, 1.3. SL90 is 0.85. Here the GSI, the PSI, the subscore as well. So it ranges between 0.6 and 1.2. The average is 0.85. So this is quite what you usually get if you treat anxiety disorders or something like that. And if you look at the dot plot, I don't like the group comparisons as a psychotherapy researcher. The best thing is always to get the single case analysis, and for that we have these dot plots. It's a little bit complicated, but not that complicated. This is every point here is one patient. And on this scale, on the X scale, you see the level of the SL90 pre-treatment, and here on the Y scale post-treatment. This means patients who are on that line didn't change at all. Okay? The more they are down here, it means those really have taken a lot of benefits. And what you see is that only one really gets worse. And this is for an inpatient treatment. When I started, I read everybody. You never can take them into a ward, bring them all together, a lot of problems. But you see only one gets worse. And but there's a whole bunch of patients we couldn't help at all. It's about 50%. And 50% really benefit. I think that's important to see. If you only do a group analysis, to say, okay, brilliant, group, highly significant difference, but we can help about half of the patients, and the other half not. So to summarize, we really could clearly show that the 3 months inpatient treatment is superior to treatment in usually 6 of 8 relevant psychopathological dimensions. The self-injury is highly significant reduced, and the statistically significant improvement is about 50%, and clinical relevant improvement is linked to responders, where you are with the SL90 beyond this 0.8 level. This means within the 2S size, we get about 45%. This treatment now is very successful in Germany. There are about 15 or 18 wards now all over the universities in Germany, and this has been replicated at least 4 times. One of those replications has been published in the Behavioral Research and Therapy in 2006. We found exactly the same data. So this is not only doable by experts. If you look at the long-term follow-up, 1 year, 2 years, you find here the data for self-injury. They go up again after 1 year, and they come down after the 2nd year. Those patients, we simply send them back where they came from, so we had no influence what happens with them. They came from all over Germany, and so we couldn't really say go to this therapist or that therapist. They had to go out. And the SL90 remains stable here. The hand-D remains stable. The gut, that's not that good. It doesn't improve any further. So we bring them up to, say, 60, what is not good, yeah? But it remains on that level. The DES, the dissociation scale, goes down, it remains stable. And if you look at the same dot plots again, this is pre-post-3. Post-3 is here 2 years after treatment. You see that none of those got worse. 5 remain unchanged. Most of them improve here. But remember, this was a slide you've already seen. This is the treatment impact within the first 3 months. And this is the treatment impact, what happens between month 3 and year 2. And this means, you remember, all of those who are within this area, they don't improve that much between the first between 3 months and year 2. So what that means is that we get the most important effect within 3 months. And maybe this is the impact of an inpatient treatment, but I really think maybe we get those who are ready to change for therapy, and then we get this effect within 3 months. And this slide is unfair, since this slide compares Bateman's data with our data, and you cannot do this, but I show you. This is not an RCT, this is simple, but the advantage is that both groups, your European group, we took this at 9. And I think you can compare a day treatment with an inpatient treatment that since the investment is more or less the same. They spend 8 hours inpatient wards. Our patients sleep here. There's not that much therapeutic effect in sleep time. But what you see here, and this is unfair, but I'm proud of, is that we get the effect where Bateman takes, let's say here, be nice, 30 months within 3 months. And I think it is a difference, whether you have a chance to get the whole thing done within 3 months, or if it takes 3 years. I'm not sure whether it works, but this is what the data are currently, and I think I'm really highly I'm a fan of Bateman and Flanagan. We really try to compare those two now and look whether a real comparison trial holds that data. Okay, summary 2. After 2 years, 48% of the DBT group fulfilled the criteria for clinically significant change. And the therapy response after 3 months significantly predicts the response after 2 years follow-up. And now the presentation starts. This is the presentation that's done now at the airport, and you get the latest of the latest data. I'm going to try to calculate. I think this is boring. I told you this is published and everyone can read it in details. So the problem, if you really look at the data, is we have a dropout rate of about 20%. And if your daughter is within this 20%, it's nothing. It's an important factor. And we have a non-responder rate of about 25%. So we cannot help about 50%. Please don't contribute to the field who always has told that borderline that DBT doesn't work, only the half of the patients work. I've never seen data of those 50% on, let's say, Bateman's data, or I think we should do this simple, since we really have to know. We don't know whether this 50% would do better in TFT or would do better at mentalization-based treatment. We don't know it simply, but this is one of the most important things we should know. And the challenge too is that the majority of those stage 1 treatment responders are still suffering from dysfunctional emotion processing. And if we often play around with that, what we call ambulatory assessment. We gave patients mini computers to assess under their daily life conditions psychopathology. And you can program this stuff, and you can say, okay, beep every hour and ask the patient how strong is the current tension and what emotions do you experience currently, under what circumstances do you experience this and that emotion. So you get a lot of information about daily life conditions. And what we found here is, what we look for is the intensity of categorical emotions under daily life conditions in borderline patients. This is 48 hours monitoring. And what we found here compared to the healthy controls, that borderline patients after treatment really experience highly significant more anxiety, anger, sadness, shame, disgust, and non-specific emotion. So that means they're simply not healthy. The next problem is shame and disgust. We've done now focused a lot of research on shame and on disgust in PTSD and in borderlines, and I think this is one of the most important stuff. But it's a also a pervasive disorder here, not only a specific emotion. It's not a problem with anxiety, it's not a problem with anger, not a problem with shame. All of the emotions are increased. So if we conduct and calculate what are the core emotional problems remaining after behavioral control, it means the number one is shame. The number two is self-contempt. Number three is guilt, disgust, and then anxiety and anger. This is our population. Maybe it's different like the population in the States, and I think English data are also different, but we don't have this anger as the major topic in Europe. And if we look how these core emotional problems are, let's say, mirrored in axis 1 disorders, most of them has PTSD, social phobia, or OCD. And this OCD has a lot to do with disgust, coping with disgust. Did you know that a lot of patients don't drink and have drinking disorders? Not alcohol, but water. They restrain water drinking since it's disgusting. So, and if you look at the data, and this is our data of Marshall's most recent study, published in the archives, she found that in the most recent study of suicidal borderline women, in that sample, 27, which means about 50% of the DBT patients met PTSD criteria at the beginning. This is, I think that's quite normal. And after 1 year treatment, only 40% of those patients remitted from PTSD. And also this decrease in PTSD was statistically significant. It is much lower than the rate of remissions usually reported in a meta-analytic study of exposure treatment for PTSD. These are data from Melanie Harn. We're closely cooperating with her. So, but this takes not wonder. If we really look at the current treatment of PTSD, and we look at the Bradley meta-analysis, and he found that about 46 of all studies excluded patients with suicidal risk. More than 60% excluded patients with substance abuse or dependence. 60% include some version of serious comorbidity as an exclusion. And this combination of exclusion criteria is likely to exclude most borderline patients, resulting in a lack of adequate empirical data to guide treatment in the PTSD borderline population. So this means we have a really good working treatment, but it doesn't work for our group. And it's a little bit like this. So this is a PTSD treatment with our patient, this is how we are looking, and then we have to change this. So, what we're going to develop is DBT stage 2. We call it emotion-focused DBT. And before we started, we had to solve some questions. The first question was, can we apply standard exposure treatments to patients with DBT and comorbid PTSD? We didn't know. And all of you are clinicians, and all of you know you cannot simply try to find this out, since they get suicidal. And you really run into troubles if you make some mistakes with them. So the clinical concerns are, do DBT patients habituate at all if you really expose them? What's about the risk of re-traumatization if you expose them? What's about the risk of suicide? And there are good data on that. This is not only clinical experience, but if we look, and these are data for our group, when we assess the intensity of what we call inattention, this means aversive tension under daily life conditions, these are borderline patients, the level of tension we always calculate between 0 and 9 and say 7 is the individual anchor when your aversive arousal is that strong that you really cannot think clearly. The only thing you want to do now is get rid of that. So this is the individual anchor. And you see, this is the average level of aversive tension in borderline patients during 24 hours. And then we look at the dissociative features. Most of you are familiar with this concept. And we simply ask, with 24 hours monitoring, are you seeing clearly? Do you feel? Do you experience the world like in fog? All these classical DSS questions. And what we found is that there's a strong correlation, about 0.85, between tension, stress, and development of dissociative symptoms. And this is unique for borderlines. This is the borderline group, this is the major depressive group, this is other personality disorders, these are health controls. So this is specific. And just to give you, to define it, usually Ruth Lanius has a really nice definition. What do we understand from dissociative features? Dissociation is the disruption of the usually integrated function of consciousness, memory, identity, and perception of the environment. We have psychological features, this means personalization, derealization. We have somatic features concerning the optical system, the acoustic system, and the pain perception. I think most of you are aware that peritraumatic dissociation is one of the most important risk factors to develop PTSD. That data of Brenner. So this means this is not only a borderline feature. I think 60-65% of women who are raped develop dissociative features during rape. The mechanisms are totally unclear. There's one idea that they have some kind of exaggerated acquisition of the stimuli. The other is it may be that the hippocampus doesn't work that well, so that the consolidation of the memory isn't working. Nobody knows exactly what happens during dissociation. And what we thought is, we really should have studied this, since the one thing is the strong arousal, and the other things now we knew is that most of the patients, or a lot of the patients, really develop dissociative features during arousal. And if we expose them, you get this arousal. So the question number one was, what happens if patients dissociate? And what we did here, we got back down to the basic research. This is a startle response study, a simple startle response. What we found is a startling tone, and you assess the eye-blinking reflex. What we found here is that borderline patients show a significantly enhanced responsivity, but they habituate. These are the green ones are the healthy controls. This means simply the slope is more or less the same. So if you prolong this slope, the idea was they habituate, but it takes them long, since they start higher. And then the scattered line here was the very first time that we saw that we really recalculated. This was post-hoc analysis, and we calculated the impact of dissociative features in startling response. And we found, oh, there's something happening. And in this simple startle reflex, the amygdala plays the important role. So there's only one connection between the amygdala and the periodic gray. So this was the very first idea that maybe under dissociation, the amygdala isn't working. The research questions were, do patients with BPD show altered emotional learning processes, inhibited acquisition, as information acquisition, prolonged extinction, maybe enhanced sensitivity to re-exposure, and does dissociation interfere with emotional learning process? Fair questions. So, this is the design to start this. And this is a simple, no, it's not simple, it's hard design. It took us 3 years to get the data now. And this is the first time I present it. This is a conditional design. This means we had session 1 and session 2. During session 1 we gave an unconditioned stimulus. This means it's a strong baby cry. It's 95 decibels. We took baby cries since we are thought that due to evolutionary context, females don't habituate to baby cries. It wouldn't have made that much sense. Males are different. So, strong baby cry, and as the stimulus, the CS+, this means it's the stimulus which is combined with the baby cry. We took neutral graphic pattern, and the CS- is also a graphic pattern, but it's not combined with the US. This is a usual design. We gave them a position, then we looked how long does it take till it is extinguished again, and then that's important. We waited 3 days. And after 3 days, we took them in again. And then we looked at a second time how strong is the learning process already. And then we did what we call reinstatement. We proposed them one time with this aversive stimulus again and looked what's the responsivity. And we did this with fMRI, and we did this with skin conductance. And what we found is this. To really look whether there are learning processes done, or successfully done, is you have to discriminate between this is the CS+, this means this is the correlation between the baby cry and the graph, and this is the reaction to the graph which hasn't been combined with the unconditioned stimulus. Okay? So the important thing is the difference between those two. And you see here, these are the borderlines. They have a very group-specific enhanced and exaggerated reactivity. Again, we find they really react much stronger. This is what you usually see if you if the amygdala, if you give them effective pictures or something like that. They react to everything. And but there's a trend for difference, but it is not that much different. It's not significant. That means our patients learn more or less equal than the health controls. And the extinction phase is more or less the same. On a long-term extinction, we assess after 3 days, there's no difference. Again, superior reactivity and one trend that it takes a little bit longer, but there's not that much difference. But if you look at reinstatement, remember, this is when we give them once again this former conditioned stimulus, then we found a significant difference between the borderline patients and the health controls. And this is very in line with Mary's data. She found out that the major risk factor for borderline is not only childhood sexual abuse, but re-traumatization during the adolescence and early adulthood. And this may be what happens with our patients, and this is an important factor since you have to be at least aware as a therapist that you could be yourself an unconditioned stimulus. Your practice could become an unconditioned stimulus, and this could rise the dysfunctional patterns. And then we look at the impact of dissociation, and then we found the green ones are those who dissociate. They do not learn at all. They do not learn, and they cannot distinguish. Of course, if you don't learn, you don't have nothing to distinguish. In the long-term extinction, it's the same. They go down, 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 down. In reinstatement, they never react. So that was, according to our hypothesis, that there's no learning process. And then to look at the fMRI, they are very, it's not the first thing. And there's a lot of arguments. You could say, okay, maybe it's a readout problem, that your skin conductance doesn't work during dissociation. And then we looked for hippocampus-driven learning processes. This is called valence conditioning. So this simply asks, we show them the two colors of the conditioned and non-conditioned graphs, and say, what do you like much or more? Clear? So usually it's clear what happens. Here are healthy controls. They prefer the non-aversive combined graphs. This is what they do here, and this is what borderlines do as well. They learn the same. And this is what dissociators do. They're totally disoriented and they don't know anything about which one was compared now to the baby cry and which was not. So, talking with Michael Fanzelo last week, we really had a nice session. Fanzelo is in the lab with Michael Davis, and he's working on historical freezing processes in rodents. And we were talking about the mechanisms. And what is the model is now that here you have the amygdala, and this is the brainstem periaqueductic gray, and this has two nuclei. This is the posterior nucleus, and this is the ventral nucleus. And normally, if you have an activation of the amygdala, there's information going down to the posterior nucleus, which activates the flight and fight system. That's the normal system. And now, if amygdala still is increasing, then a shift happens from the posterior to the ventral nucleus. And this ventral nucleus now, here, blocks the amygdala and takes it down. and what happens is numbness. So this is the clinical level. They feel numb, and they don't learn. And we have data, Christian Schmal from my group, we were lucky to publish it in the archives now this year, is he looked at pain processing borderline patients under stress conditions. And what he found here is if we give them laser pain during laser pain in the fMRI, we found that borderline patients exhibit a significant decrease of the amygdala response compared to the health. Compared to the healthy control. So this is the second time that we found there's something to do with the amygdala not only increase, but under circumstances decrease. And then we looked at the fMRI during our conditioning experiment. And here we made a split half between dissociators and non-dissociators. And what you see here is the difference between those patients with high dissociative features and low dissociative features. This means simply the reaction to the baby cry. And so that means there's a much stronger activation here in the insula, in the maxilla, and in the dorsal lateral prefrontal cortex. This is the impact of dissociation on the fMRI. The same is true for the hippocampus. There's a negative correlation between dissociation and hippocampus activation, which means it has something to do with memory consolidation as well. And at the final impact, this is what the learning process, the conditioning process, and pain in the insula, where we see in the fMRI here, this point here, that those who dissociate don't learn in the fMRI level as well. So what did we learn? We see they have an enhanced responsivity. This means we have to taper down the level of arousal during the exposure sessions. We have to actively taper down. We have to apply prolonged sessions. We have found an enhanced reinstatement. This means we should include cognitive stimulus discrimination. We have to use the cognitive processes during the exposure treatment. And we know now that learning is totally attenuated during dissociation, and we have to actively block dissociative stage. So, based on that, we developed this DBT stage 2 treatment module. And what we have now is we start with a skills group and we teach them in emotion regulation. Emotion regulation, what means they learn how to taper down actively their emotions and how to taper down actively dissociative states. You can teach it to the patients, they learn it. We have 20-minute mindfulness training. This is since we really are convinced that mindfulness helps them to develop something what we call metacognitive awareness, which means they get a distance from their activated emotions. We have individually, forget that. Then the individually tapered based component analysis is we first teach them discrimination training. Then we have cognitive interventions and prolonged titrated exposure, and then testing new behavior. This is the okay. So the prerequisites to take them into stage 2 treatment, which is mainly exposure based, is first they have to be capable to control for crisis generating behavior. This is DBT stage 1. They have to be able to control for crisis generating environment. This means re-victimization partners, etc. They have to be able to control for therapy intervening internal and external variables like automatic dissociation. We have to teach them first how to do this. Then severe anorexia and payment diseases. So the modules are, I already told you, I was talking about titrated prolonged exposure. And why this makes sense to the data of Marsha's group, where she did prolonged imaginal exposure on, and she assessed the specific emotions. And look at that, this shame after and during imaginal exposure. And it took 16 hours, 16 sessions here, till shame comes down. The same is true here for guilt. And the fact that this is successful, you see here, that vice versa, positively correlated and negatively correlated with the going down of shame, the sadness, and here anger rises. And this is, I think, this is a fine therapeutic effect. The change between shame and sadness, I think this is what we really want, and trauma therapy has a lot to do with grieving. We now have consecutively admitted 19 patients to the treatment. All of them have severe chronic PTSD. 19 of them, all of them, childhood sexual abuse. Most of them have current BPD. About 1/3 has lifetime BPD. This means they have 4 criteria now. They have been consecutively admitted. What is important, we don't select them. For all of them had suicide attempt, self-interest behavior, and current severe dissociative features showing 17. And these are our pre-post results. The PDS, this is the post-traumatic stress disorder symptomatology. We started with 2, that's very high. The data of David Clark and so on, who published the first data on this is the average is 1.8, so they're over the normal level. After 2 weeks of treatment, it goes down to 1.7. This is not that good, but here, 6 weeks follow-up, we found that it goes down to 1.3. So we have an effect size here, pre-post effect size of 0.95. And the BDI is doing fine. The depression goes down a little bit more quickly. I think this is due to the fact that the exposure treatment is really a harsh thing, and it doesn't make you feeling better within the first 2 or 3 weeks. Again, if you look at the dot plots, here you're familiar with this now. Here those groups, nothing happens. 2 get worse, but most of them improve after treatment. And this is only keeps the patients. Thank you.